And we have our last speaker, Dr. John Berk, who's here from Boston University, who is going to bring home the entire session with a discussion about tetramer stabilizers, but also future targets and the development of new agents in amyloidosis.
Jeff, thank you very much. Great symposium. Sasha left me nothing to talk about. That was a very comprehensive talk. So you guys can sit back. I'm going to whip through some slides because I really think the essence of the whole process are the questions that you guys have. But it's that, he brought up a lot of very important topics. Okay, tafamidis. This is the third New England Journal article for the year. It's a little ridiculous. We've got an orphan disease and drug development for 3 companies. So why is there a lot of enthusiasm about tafamidis? Well, this is a very safe pill that has been studied at 20 milligrams for neuropathy. And now this is the first cardiomyopathy trial in this space. So a lot of interest in the design and outcome measures. And to top it off, it's a successful trial. This is looking at a couple of doses, as we'll get into. Why is it important? Because as Sasha pointed out, probably about 10% of men 80 and older will die with significant amounts of TTR amyloid in their heart. And by the 2012 census in the United States, that would equal over 400,000 men. So it would quickly challenge the definition of an orphan disease. All right. What's the trial? The trial is taking 441 gentlemen, and I can't remember if there are any women. I don't think so. And then randomizing them 2 to 1 to 2. So there would be 2 going to 80 milligrams of tafamidis, 1 going to 20 milligrams of tafamidis, and that's the treatment group, obviously, and then 2 going to placebo. There were a significant amount of dropouts for a 30-month trial. That's not surprising when you're dealing with people with cardiomyopathy. And we'll get to the characterization here in a second. If you look at the consort diagram in the article, you'll see that approximately 15% deaths were identified in the treatment arm and 21+% in the placebo. But that's a little deceptive. Actually, there were 29.5% deaths in the treatment arm and 42.9% in the treatment arm. So there were less deaths in the treatment arm, as we'll see. And you can look at the completers here, and not everyone who entered and was randomized finished, clearly, as we've identified. So effectively, it's a trial that people were dying to get into, and once they were in the trial, plenty of them died. The demographics here, this is a trial of old men, largely. So clearly there were some women, none in our center. There was a predominance of wild type, and by predominance I mean they fell out of the sky once the trial opened up. And the variant population was limited to less than 25%, although the design of the trial was to have at least 30% variant TTR. And it was predominantly white men. So what do we know in terms of functional measures here? The New York Heart Association class 1 and 2 dominated the trial. New York Heart Association class 3 was represented in higher numbers in the placebo group. And New York Heart Association class 4 is absent because they were excluded. If you look at biomarkers and structural measures, you see that the two groups look remarkably similar, but in the game of amyloid cardiomyopathy, troponin I of over 0.1 is real disease, and so these are people who have considerable disease. We know by the thickness of the heart that this is with an upper limit of 11 or 12 being normal. These are people who have considerable amyloid burden in the heart. And the global longitudinal strain is markedly reduced, with a normal being minus 18 to minus 22. One other thing I wanted to point out here. So this is a cohort of older white men with advanced wild-type TTR. That's the way you should think about this trial. What were the endpoints? So all-cause mortality and the frequency of cardiovascular hospitalizations were the two essentially co-primary endpoints, although the statistical analysis is a hierarchical procedure in which all-cause mortality got preference. And you can see on this Kaplan-Meier graph that at about 18 months, the two lines disappear, and that curve divergence there clearly indicates that at that point we're seeing less mortality in the treatment arm. And tafamidis actually reduced mortality by 30% by 30 months. If you look at time to first cardiovascular hospitalization, which I present because they offered a Kaplan-Meier graph, and I think it really represents the essence of things. So even though it wasn't a primary outcome measure, you can see that at 9 months, so 18 months, we're seeing mortality diverge, and at 9 months, you can see that the first hospitalization rates are starting to diverge, with treatment arms doing better. And then if you look at lower down in the slide, the frequency of cardiovascular hospitalizations, which was the second primary endpoint, you can see that there was a reduction in the cardiovascular hospitalizations by 32%, and overall in simply the rate of the first-time hospitalizations of 20%. Quite impressively, functional measures, obviously not mortality or hospitalizations, but 6-minute walk test, and then the Kansas City Cardiomyopathy Questionnaire, so quality of life. You can see that at 6 months, these curves diverge. And while there's not improvement with tafamidis, I think it's important to remember, it's a lesser decline, so it's a double negative here. You don't get credit for full improvement, but people did better on treatment, whether for quality of life or a 6-minute walk. But there's a lot of strata here, and the article really offers very little except this composite representation of the primary analysis method, the Finkelstein-Schoenfeld process, which is taking a pairwise analysis of treated and untreated in each strata and analyzing it. But what we have the opportunity of seeing here is the only breakdown, and that is we get pooled data looking at survival analysis and cardiovascular hospitalizations, the primary endpoints. But we get to see how people with variant or hereditary TTR did versus those that had wild type. We can see the functional assessment of their cardiomyopathy, and then actually dose. So a lot of data to look at here. Before I even get to that, I should say that overall we see that by the analysis chosen, there was statistical significance for pooled tafamidis over placebo. And you can see that with the forest plot here and the meridian that survival analysis was significantly favoring tafamidis. And then if you look at the cardiovascular hospitalizations, even more prominent effect. Now, if we look at the breakdown of the type of TTR, we can see that in the variant population, or hereditary, that for survival, it did not meet statistical significance, nor in cardiovascular hospitalizations. But in the wild type group, while the survival analysis independent of the grouped analysis over here did not meet statistical significance, we can see that cardiovascular hospitalization did, and did so in a prominent fashion. If you look at the degree of cardiomyopathy, so in class 1 and class 2 versus class 3, the statistical significance is found in survival and really prominently in cardiovascular hospitalization rates for those that have less severe cardiomyopathy. And the people who had more severe cardiomyopathy may be better off not treated, because you can see that the cardiovascular hospitalization rate actually goes up when they're on treatment. And what about the dose? Well, this is by design, there are twice as many people treated with 80 milligrams, which again is 4 times the neuropathy dose that we've known and experienced, particularly in Europe. And then 20 milligrams was sort of brought along, I think, almost as a gesture. And you can see that for survival analysis, it's 80 milligrams that's really driving the statistical significance and cardiovascular hospitalizations. Although I would note that even though 20 milligrams did not afford a survival signal here, that there was a significant change in the frequency of cardiovascular hospitalizations. Okay, so we're seeing functional benefits, that is in 6-minute walk test. We're seeing quality of life that is more stable. And now if we look at the the architectural change over 30 months, which is a considerable period of time, we see in the tafamidis group alone that regardless of the measure we're looking at, there is no improvement. If you look at the difference between the deteriorations or the progression seen in the tafamidis group versus the placebo group, that if you look at stroke volume, there is a difference. That is, the decline in stroke volume was less prominent in the tafamidis group than in the placebo group. And if you look at various iterations of strain, there was a difference, but in global longitudinal strain, there was not. All right, so where do we stand? Sasha's talked about the mRNA degradation drugs, and we've heard now and seen, I think, impressive results from tafamidis at 80 milligrams. What about diflunisal, a drug that you may have heard about, maybe never saw the primary data? This was presented back in 2013 in Rio. And the results of those trials in many ways replicate what we're seeing, and Sasha shared with us from the RNA agents here. So on this graph, we're looking at the neurologic impairment score +7, and on the abscissa here is time with data collected at 12 and 24 months. And you can see with the red curve that the placebo increase or worsen their neuropathy significantly. What does 20 points really mean? 20 points means that you can't get out of a chair without someone helping you or having a pull. that you probably at that point you entered the trial not using a cane, but now you need it. Or if you had a cane, you're using 2. And if you had 2, now you're using a walker. So this is significant deterioration over a 2-year period. To put it a different way, in diabetic polyneuropathy, you have to observe people over 2 years to see a 2-point change. This is 10 times as fast as diabetic polyneuropathy. Yet despite that, diflunisal was able to significantly blunt the progression of disease, and it appeared in people who took it for 2 years that it was remarkably stable. Indeed, in 30% of people receiving diflunisal for 2 years, there was no change in that point score system. Moreover, diflunisal had significant quality of life benefits. And you can see on these scales with this metric, which is the short form 36, that as point totals are going down, you're getting worse. And there was dramatic worsening in the physical component of the quality of life, and as well was noted with the mental. And you can see that unlike some of the quality of life data that was presented earlier, that there's actual improvement over time in people who are taking diflunisal. What about survival? Well, we've seen that tafamidis, certainly at 20 milligrams for cardiomyopathy, alters the cardiovascular hospitalization rate. It's not so clear about survival for cardiomyopathy, but this is neuropathy data from Portugal, which is really the epicenter of that disease in the world. And it's a little bit complex here, but this green graph captures the mortality rate in people who are untreated. The red graph are in those that had liver transplant. And then the blue are in those that had tafamidis. And the data were collected in the same epoch. So we're talking about similar patient population. So clearly, tafamidis at 20 milligrams has survival benefits. So have we gotten anywhere? We're talking about very sophisticated and ultimately expensive medications. Has that really altered the conversation of therapeutics? So in this graph that you've seen multiple times with the neurologic impairment score on the ordinate and on the abscissa is time, we see that placebo worsens and that in this case diflunisal stabilizes. But now we've changed the conversation. So the patisiran data shows that not only can you stabilize, but you potentially and apparently can improve sensory nerve function. That is really a paradigm shift. So what about improvement? So if you look at the neurologic impairment score and you survey the patients to see who among them actually improved their scores, in the patisiran trial, 56% of those people actually improved their neurologic scores. And in the inotersen, it was 37. So these drugs can promise the potential of some improvement in nerve function. Well, what about histologic evidence here? So in this pictorial, histologic evidence is that if you biopsy sweat gland nerves, and one is depicted on the left, and then 24 months later it's depicted again, you see with the green lines, which represent new nerve formation, that there's a reinnervation of these sweat glands. And if you do serial biopsies over time, you biopsy the lower limb and the upper limb, you can see that the lower limb, there's a suggestion of some increase in the density of these small nerve fibers, again, over 18 months. But if you biopsy in comparison more proximally, you'll find that the nerve fiber density is increasing much more rapidly. This is a disease that affects the nerves from the distalmost point, so it's considered a length-dependent neuropathic process, sort of like a fuse burning up from your feet. And so the repair process, you can imagine, would be in the opposite direction. And these nerve fiber density data suggest that that's actually happening. All right, so we've got these fancy new drugs. The idea is to knock out the protein that's misfolding and forming amyloid. And this graph here captures the change in neurologic function, with a rise being worsening neurologic function and decline being improvement. And on the abscissa, we have the TTR level at the end of treatment relative to the baseline. So we expect that all the dots are going to head leftward, and ideally, we're going to be looking at these individual points showing that there is stabilization or improvement. What do we find, however, that there is about 25% of people who either despite having a decline in their TTR levels or not having such a decline, actually have a rise in their neurologic impairment score, a slight worsening of their neuropathy. And this is for patisiran. And then in inotersen, we see the same is true. So there's a small population here that it's not addressed by these drugs. How do we manage this? What alternative therapies are there? Well, Ashu and Sasha have done a remarkable job in making my life easy. So what we have here is that you have the transcription, translation, and you have unfolded protein. And with the stabilizers, Gesundheit, we're trying to actually maintain this tetramer. If there are no monomers, there's no amyloid formation ongoing, theoretically. So we've heard something about doxy and TUDCA, a bile salt derivative, and also the antibody-mediated clearance that Jeff has so eloquently discussed. And just to reiterate here, so what Ashu showed you was that in a human transgenic mouse, you have formation of TTR as the immunohistochemical staining proves. And then if you treat with doxy and TUDCA, it just disappears. We anticipated that this was going to be the answer. And when we did a phase 2 trial with 25 subjects and we gave them doxy for a year, not only did we find that we have more sun, perhaps, on our side of the pond, and people were blistering and looked a mess, with many of them having to drop, that when we looked at heart, kidney, and liver measures, we did not see improvement. We didn't have a placebo group, so we can't tell you whether this is true stabilization. That would be the optimistic interpretation. But we did not see what happens in mice. Antibody disruption you've just heard about from Jeff. I don't need to go through this again. But I think to date, it's fair to say that we've been, our hopes have been a little bit underwhelmed. It's been a frustrating process. So will 11.1 F4 or PRX004 prove successful? We hope so, because disrupting amyloid deposits theoretically should have benefit. Okay, so this is the scheme as things stand at the moment. Where do we move from here? Proteostasis enhancers or regulators appear to be the next level of serious consideration other than CRISPR, and I think that the off-target effects of CRISPR-Cas9 need to be considered. So, what about this proteostasis network? There are a variety of conditions, stimulus, that result and promote protein misfolding and aggregation. And they're happening throughout our lives. As we age, oxidative stress and nerve inflammation are increasing. For certain genetic mutations and perhaps even polymorphisms become important as we age. So this process is increasing, and it bombards the endoplasmic reticulum with unfolded protein or misfolded protein. So the quality control center is challenged. There is an adaptive cellular proteostasis network, and it manifests as the unfolded protein response that is upregulated when the endoplasmic reticulum is stressed. And the process is to deal with the excess oligomers and aggregates in an effort to either degrade them, to rescue proteins that have not reached a terminal point, or to induce cell suicide if necessary. How is this happening? So the unfolded protein response has some different pathways. There is the ubiquitin proteasomal degradation arm, which is the associated degradation, the ERAD. There are autophagy degradation pathways illustrated here by a lysosomal degradation. And then there are ones that we don't think about very often, but assisted folding through the mediation of chaperones. So ultimately, the UPR functions are to degrade the unfolded proteins, to salvage wild-type protein as much as possible, to limit secretion and aggregation of variant protein. Mechanistically, what are the targets? So in the ER membrane, there are 3 transmembrane signaling pathways. The inositol requiring enzyme 1, Berk, and ATF6. So with increased stress, you find that there is dissociation of BIP from these 3 signaling pathways, and that activates each of these. So with IRE1, you get ERAD components being upregulated, but as well chaperones. So there's not only degradation, but promotion of rescue of some of these proteins. And ATF6 has much the same function. The Berk signaling pathway is particularly instrumental, and you can see that stimulation phosphorylates EIF2 alpha, so it downregulates protein synthesis in an effort acutely to decrease the burden of new protein misformation, but as well, it can also result in activation of apoptosis. So this is the pathway blown up a little bit more. It's important to understand that Berk signaling is clearly integral to neurodegeneration. And it's, if you look for Berk activity, in brain specimens, you'll find that it's temporally and spatially associated with areas of injury and protein aggregation. It's constitutively upregulated in a number of key neurodegenerative diseases, and that inhibition of this signaling pathway can actually result in significant reductions in hippocampal neuronal loss, spatial memory loss, neuronal death, and pathogenic p-tau. So it seems to be a critical pathway, and we now have, at least biochemically, inhibitors to regulate some of these pathways. And you should note that trazodone actually is one that can alter the activity of Berk. So, in summary, the data I've presented is that tafamidis extends survival in early cardiomyopathy and wild-type TTR disease, but it also extends survival in those that have MET30 polyneuropathy, which is what exists in Portugal. Remarkably, the stabilizers do not induce heart remodeling or nerve repair, although they impact disease course. They effectively slow disease. The RNA agents have the potential of improving disease. But 25% of patients do not respond to TTR suppression. And as you've already heard, antibody and doxycycline-based therapies seem to be better for transgenic mice than humans. It's clear that there's association of ER stress and UPR activation with neurodegenerative disease. And as such, it appears this is an important therapeutic target for prevention of protein folding and aggregation disease, particularly in our aging population, which is what the tafamidis experience is all about. And as people live longer, the second compartment of disease for TTR, and particularly in the variant population, will be the brain. None of these drugs cross the blood-brain barrier, and these people will die not of their peripheral neuropathy, but of central brain disease. Thank you very much.
Thank you.